Now we move on to our second section, that is we will be discussing the morphology of the flexion-distraction injuries. In this we will be discussing the how to assess the integrity of the posterior ligamentous complex and what is the posterior ligamentous injury, what is bilateral facial dislocation and what is unilateral facial dislocation, and what is the treatment of unilateral as well as the bilateral facial dislocations. As I told you, the mechanism of distractive flexion mechanism is such that there is actually the neck is going into hyperflexion due to certain deceleration, and due to hyperflexion what happens is that the one vertebral body actually translates over another, and this can lead to distraction as well as a flexion type injury. What the compression could be occurring over the anterior level of this cervical vertebral bodies, and the posterior spinous processes and ligamentous complex could be opening up due to the hyperflexion of the cervical spine. This leads to a classical pattern of distractive flexion mechanism. Structures fail sequentially from posterior to anterior with progressive instability. Initially there is only ligamentous disruption, then there is opening of spinous processes, and as the deceleration continues the neck goes into further hyperflexion, this actually anteriorly vertebral body compression fractures as well. So when we are dealing with posterior ligamentous injury, the X-rays usually show an increased interspinous gap. Flexion views should confirm stability. On the flexion view, if this patient is neurologically intact, then only we can go for these views. There will be, if the flexion views show stability, there is no further opening of these interspinous ligament, there is no translation of the vertebra, then we can go for cervical spine immobilization with conservative measures, that is a semi-rigid collar and repeat flexion views at 6 to 12 weeks. If there is greater than 11 degrees of angulation when doing the flexion views, this means it's an unstable injury, or it is greater than 3.5 mm of translation of one vertebral body over another. This means the mechanism actually still exists and there is no posterior ligamentous stability of this vertebra. Therefore, these are unstable, and these potentially unstable fractures need surgical fixation, because even if at this time the neurological status of the patient is intact, can lead to complete spinal cord injury, which could be disastrous for the patient. Now coming to another type of injury, which is called as bilateral facet dislocations. What are facet joints? Actually, these are the articulation in which the one vertebra articulates with another vertebra. As you know, the spinal cord has movements called as flexion, extension, and then there is rotational element as well. These are type of movements where acting of the facet joints. If the facet joints are disrupted on one side, it's called as unilateral facet dislocation. If both the facet joints on the right, both sides of the vertebra are disrupted, this becomes the bilateral facet dislocation. What are the signs and symptoms? This is actually a severe flexion injuries with complete disruption of the posterior ligamentous complex and spine instability, often with the cord damage. Now the mechanism is always the flexion-distraction injuries, and that is what happens is there is hyperflexion of the cervical spine with continuous deceleration and so excessive motion that eventually both the facets actually get displaced or disrupted. So the mechanism of articulation between one vertebra and over another is actually disrupted, and therefore one vertebra may rest over another vertebra in a severe flexion deformity. Occasionally facet fractures as well, they can also be associated with facet fracture dislocation. On lateral x-rays, they actually show the disruption of the radiological lines. And how would they show up? Whenever we are viewing the lateral x-rays, we need to look at the anterior vertebral line, posterior vertebral line, as well as the spinolateral line and spinous processes line. If you see this x-ray over here, or let's see this is the anterior vertebral line over here, then gets disrupted. This is the posterior vertebral line, it's also disrupted. Then comes the spinal lamellar line, doesn't look normal. Spinous processes look, there's no fracture, but this also line is disrupted. If you appreciate, this is the C2, this is C3, this is C4. C3 is actually translated into flexion over the C4 vertebra. This is a classical, usually a flexion distraction mechanism which leads to either the unilateral or a bilateral facet dislocations, or may not be associated with fractures. So there is disruption of anterior vertebral translation. Half of the body width is usually actually translated anteriorly. If it's more than half, this is a bilateral. If it's less than half, it's usually associated with a unilateral facet dislocation. Spinous processes are aligned at least on the AP view. There's no rotation, but spinous process line over the lateral view may also be disrupted as well. Now coming to the unilateral facet dislocation. If you see, this is C2, C3, C4, C5 and C6. C5 is actually translated over the C6. You can appreciate disruption of anterior vertebral line, appreciate disruption of posterior vertebral line as well as spinal laminar line. But this displacement is not more than the half of the vertebral width. If it's less than half, these are actually means it's a unilateral facet dislocation. These are also distractive flexion injuries and distractive flexion rotation injuries with a single facet joint dislocated and cord injury is less common. So the injury mechanism is such that the neck is going in hyperflexion, but the deceleration has actually stopped. Therefore, only the one facet has failed, other is still intact. But the problem with this kind of injury is that with both facet failing, there is only hyperflexion flexion distraction injuries. But with unilateral facet failing, there is actually rotation of the fragment as well, leading to the spinous process actually rotates over another spinous processes. With that kind of injury, when you look at the lateral x-ray, this classically produces a bow tie sign. When vertebra displaces one less than the one half of the body width, as I already told you, this rotation of the faces can be felt to the injury level, resulting in a typical bow tie sign. Because why? The one vertebra is not only translated forward, although less than half of the body width, but there is a flexion as well, leading to rotational element as well, and this rotation produces a classically bow tie sign. With bow tie sign positive, this is usually indicative of unilateral facet dislocation. On AP view, alignment of spinous process is distorted. Why? Because the spinous process is actually rotated. One of the spinous process rotates, and on AP view you can probably see there is usually a disrupted spinous process. If it's left untreated, although at this point the patient may be neurological intact, but patient may eventually develop neck pain, nerve root symptoms, and potentially remains unstable, and eventually it could be a serious complete spinal cord injury as well. So that is very important that unilateral facet dislocation and bilateral facet dislocations are potentially unstable injuries and they have to be managed accordingly. Now, when we talk about the important point, the take home message is that whether the injury is stable or unstable. If it's unstable, you need to fix it. So dislocation is now how to fix it, then it comes the management point. Dislocation is reduced as a matter of urgency. So because it has actually produced a hyperflexion distraction type of injury, what we can do is we can reverse this mechanism by producing traction by using a cervical tongs, and then we can skull tongs can also be used, and then first the traction and then slight hyperextension. But with the neurological outcomes improve with earlier reduction. When we are doing this closed cervical reduction, what is important is to make it sure that we do not further aggravate the injury, and we need to monitor the person neurologically as well. If the neurological compromise starts to occur, we have to stop there and then. Now, after the closed cervical reduction, if it is successful, well and good. If it is unsuccessful, we need to go for open reduction of this cervical spine injury. And if we have reduced it with the closed cervical spine injury, then we can surgically stabilize the posterior ligamentous complex by posterior approach and this anterior translation by anterior approach. And disc may be damaged because it has actually there is a Flexion-Distraction mechanism, so disc may be damaged at the time of the injury and eventually may lead to ankylosis of the disc. And there is always this ankylosis leads to decreased range of motion, neck pain, some amount of rigidity and stiffness may be there, but what's important is the patient may not be quadriplegic and there may not be neurological compromise. So pre-reduction imaging are important. X-rays we need to get it, so we need to diagnose the injury first. Then we need to get the CT as well to know the morphology of the fracture, if there is a vertebral body fracture as well. And then we need to get an MRI as well. MRI will tell us details about the discoligamentous complex, whether it's disrupted or not. Once we have got the pre-reduction images, then what we need to do is that we need to evaluate whether this associated disc collapse or not. Although that is not actually related with the post-reduction prognosis of the patient. Then this is the method of the cervical traction we do. Usually the skull tongs are placed over here and the patient's initially traction is applied. With initially the first amount slight flexion is actually helpful, because this is how then from once the fragments are distracted to a certain limit, and keeping assessing the neurological after every traction. As we increase the weight over here, the neurology of the patient is assessed continuously, and if there is a slight hint of neurological compromise, the traction is actually stopped there and then the neck is actually slightly extended so that the fracture fragments come back into the place. And as it is a flexion distraction injury, then we have to first apply the traction and then extend it, the reverse of the injury mechanism. IV muscle relaxants and bolsters beneath the shoulder are actually placed. Neurological examination should be repeated because we do not want to further harm the patient and do not want to increase the neurological compromise of the patient. Reductions have by initial 20 degree of flexion, but once the traction is done, then it can be given slight extension at the neck to reduce back the fragments. After the reduction, the neck is extended, as I just told you. Once we have reduced it, now if you see, this is after the cervical reduction, it's very much stable. Anterior vertebral line is there, posterior vertebral line is there, and spinal lamellar line is very much intact, looks intact. Once that phase has reached, we can go for surgical stabilization, and usually after even the close reduction, you still need another CT and MRI just to see whether there's any canal compromise or not. And then surgical open reduction may be required in 20% of the cases. That is, anterior and posterior stabilization may be necessary as well. How to do the stabilization? That is, anterior approaches, disc is removed from the canal, facets indirectly reduced by the manipulation of the vertebrae, and interbody fusion is done with bone graft, cages, or even the plates as well. And posterior approach is actually done to about the discoligamentous complex. Facets directly reduced, fixed with lateral mass screws, because you do not have strong pedicles over the cervical spine, so we have to place the screws in the lateral masses. Then replace less robust interspinous wiring techniques can be used, because these screws of the lateral which are being placed in the lateral masses can be joined with interspinous wiring. And patients with usually high energy complete spine patient may have already complete spinal cord injury as well. So what we need to make it sure is that this patient undergo aggressive rehab as well, because that even if the dislocation is reduced and canal compromise has been decompressed, still the spinal cord injury which has occurred at the time of injury can still be very debilitating and problematic for the patient. So they need, after even the surgery, then aggressive rehab as well. So most of commonly it's always a combined anterior and posterior approach, because the mechanism such that is always associated anterior vertebral body fracture, discoligamentous complex disruption posteriorly as well. So usually we have to go for both the anterior as well as the posterior approaches. Combined approaches are used, and especially in the neck, then anteriorly as well as posteriorly needs to be fixed as well. In this section, we have briefly gone through what are the flexion-distraction injuries and what is the mechanism of flexion-distraction injuries. Usually, this is injury which occurs in which the neck goes into hyperflexion. With continuous deceleration, this leads to a distraction of the type of injury in which the one vertebra translates over the another vertebra with fracture of the posterior ligamentous complex or disruption of the posterior ligamentous complex. Now, if there is less than half of it translated, this means most likely associated with unilateral facial disruption and dislocation. And if it is more than half, this usually indicates that there is a bilateral facial dislocation. These both are potentially unstable injuries. Once we get the x-rays, the CT and MRI, we need to usually require a surgical fixation. And surgical fixation can be done by both the anterior and posterior approaches. Anteriorly, the grafting and the plating can be done, or even the cage can be placed for the fractures of the vertebral body, and posteriorly the ligaments can be fused by use of a lateral mass screws, and interspinous wiring can be placed for the stability of the posterior ligamentous complex. Thank you very much. Keep watching sqadia.com.